We're talking today about a unique concept in the management of cancer. And I have the authors of a great article from Nature Reviews, The Evolutionary Dynamics of Carcinogenesis and Why Targeted Therapy Does Not Work. Doctors Bob, introduce yourselves
Robert
and talk to
Gillies,
us.
Robert Gatenby. Hi.
So tell us about, why doesn't targeted therapy work? Because now this is the silver bullet that we all have been waiting for. We have all these wonderful drugs that say we can target the androgen receptor and all these other things, and they're going to give us extended survival, but yet you don't believe that's the case.
Well, Virgil, the concept of targeted therapy is you can identify a particular molecule that cancer is expressing and that it's dependent upon for its survival, and you're able to treat it with a drug that will inhibit that molecule. And while we've been able to show that drugs can be developed against specific molecules that are present in cancers, the reality is that cancers are not homogeneous, and not all the cells are expressing that molecule. So within any given tumor, there are going to be cells that don't have that molecule or don't have that target and are not dependent upon it for survival. And what you end up doing with the targeted therapy is selecting for those cells, these other cells, to grow out. And most often what we see is that these other cells are resistant to drugs in general, and they're very, very difficult to kill. We call them chemo-resistant, and you end up with a chemo-resistant tumor. So I think that the problem is in the concept of visualizing tumors as well-mixed, homogeneous systems, and they're not. We know they're not.
Okay. Now, Dr. Gatenby, you're looking at in your research the way of beginning to look at many of these cellular structures that are out here that we can begin to really target, really create targets for therapies. Now, you talked about the idea of our being able to develop a personalized approach to doing this. Would you elaborate on that a little bit more in terms of how you see this happening in the lab and then ultimately in clinical practice?
Sure. I think that right now what happens is that what are called biomarkers are used as a one-time therapy. So if your tumor expresses some biomarker, that's your sign to use a therapy. The problem with that is that once that therapy fails, as it always does, then the biomarker is useless. And so we would like to provide ways to guide therapy throughout the course of the disease, where the biomarker represents a computational model, so a computer model that's always being updated by the data on the patient himself, so that there's a constant inflow of information as therapy causes changes in the cancer, some of them good, some of them not good, evidence of toxicity and so forth. And so just like a hurricane model that's always being updated by current data and then projecting forward into the future, that each patient will have this computational model that stays with him or her throughout the course of the therapy, always being upgraded. And so even when you go to second-line therapy or third-line therapy, the computational model is always there guiding what would be the optimal therapy for that person.
That's a great thing. Now, you talked about the idea of beginning to develop the baseline for this kind of therapy using the, I guess, second line therapy in terms of a hormonal, a Lupron-based product that would give you an idea of how the patient can potentially react to the ongoing therapies. How do you see that being ultimately used in clinical practice?
Well, in the specific example that you mentioned, what we're doing is using the patient's initial response. This would be for patients with prostate cancer. We would look at their initial response to the chemical castration, usually Lupron, but there's other drugs, and we watch how they respond, and that's fed continuously into the computer model, which then develops a computational assessment of the different subpopulations within the tumor. What are the populations that are present at the beginning? How are they affected with the initial therapy? And then as the tumor begins to recur, what are the combinations of subpopulations that are present, giving rise to that increase. And by doing that, you can then predict going forward what you think would be the best therapy next. And it's more than just predicting the best drug. It's also predicting the best dose. In other words, we always right now treat with the maximum possible dose, the idea being to kill as many tumor cells as we can. But we know that typically results in the release of the resistant cells. It actually maximally selects for them, and it eliminates their competitors so that they actually have a completely open field to proliferate. So our goal with this is to not only have the computer give us what the best drug is, but also what are the subpopulations that exist, and given that, what do we think are the best dosing schedule for that drug that would allow the longest progression-free survival. So what we want to do is not only get a response, but we also want to maximally delay the growth of the resistant cells to that therapy.
Now, when you look at response, are you looking at PSA levels, PSA velocity? What are the metrics that you're using to chart response?
Yes, we're using both of those things. We're looking at PSA decline, the rate of decline, the rate of increase. We're looking at the nadir value compared to the baseline value, and so those are pieces of information that we have, and we can time those against the onset of therapy, and we can also look at the length of time at which a patient is at a nadir. And basically, we can then go backwards and say, well, what are the populations that were present at the beginning that give rise to this set of results? And then, well, what would be what are the populations that are present at the next time when you have to start another therapy? And so with that in mind, what would our computer predict would be the best therapy? And what would be the outcome if we just give standard therapy?
Okay. And it goes without saying that this is highly individualized, so every patient has their own trajectory. Yeah.
No, I think is wonderful, because I think that's ultimately what we want to get to, is being able to say that for you, this is what you need to have in terms of a combinatorial effect, and instead of saying just one drug you're going to take now, and then if it doesn't work, you then take another drug off the shelf. Maybe you start with 2 or 3 drugs at the same time that might have maximum benefit in terms of extended survival, etc. Now, one of the things we talked about, and again, Bob, you really looked at this in many cases, is the whole thing of imaging, and that maybe we need to do a better job even before we start thinking about treatment failures, but really in identifying the tumor itself in terms of being able to have an optimized approach before we put a knife to someone or stick them under a radiation, therapy. Why don't you talk a little bit about this whole idea of imaging and how you see that being used progressively as the disease moves forward?
So, every cancer patient, even before they get a biopsy or get a knife, they get an image. And it's my strong belief that we don't do enough with these images. Images contain a wealth of information that's not exploited. So we and our colleagues have been working over the years to convert images to mineable data in order to pull out either prognostic factors or information about the subregions within tumors. We know that tumors are highly heterogeneous and that they can exist in regions. They can have distinct habitats within them. And these habitats are accessible by modern standard of care imaging techniques. And often these images are obtained in prostate cancer patients, either with a body coil or an endorectal coil. Obviously, the endorectal coil gives a much higher resolution, but these are obtained routinely. And we don't do enough about extracting all of the important information. Furthermore, the identification of habitats can also direct biopsies. if you do a biopsy in a patient and not knowing where the biopsy is coming from, then you may get some molecular information about one part of the tumor, but you can't base the therapy against the whole tumor on one uninformed biopsy. It has to be image guided, and quite frankly, the idea of taking multiple biopsies from a prostate cancer patient is not unusual, and this could be done in a much more informed way with interaction with imaging.
Now, we've seen the recent approval of this new drug or new test agent, rather, that says they have the ability through a variant of the PSA to be able to predict which patients are going to become more aggressive in their cancers. How do you see that kind of a test integrating itself to the kind of work you're doing in your research to be able to develop truly a true target of therapeutic approach for patients?
Well, you're talking about the Pro PSA?
Well, you got a couple. You got the Pro PSA, you got the PCA3, but most recently you've got the Oncotype DX test.
Well, see, the Oncotype is from a biopsy, and obviously, like I just said, the biopsy has to be image guided. Otherwise, it's going to be very, very difficult to personalize the management of the cancer based on a single 100 milligram chunk of tissue. With serum biomarkers, though, it's a completely different story, because serum biomarkers have the advantage of representing the integral over the whole tumor. So they really do represent the whole tumor. And consequently, I think that they have great value. And, this talk recently about, going away from PSA because it's such a terrible biomarker. Right. I don't know any urologist in the world that would want to go back to the pre-PSA days, because, then the incidence decreased, but a lot more men died because they presented with
advanced stage disease, right?
Disease. So the Gleason grades were much, much higher. So a serum. We just need better. Good serum biomarkers would be the first line of defense, the first line of information. They do represent the entire tumor, and they would always be followed up by imaging. I'm just saying, do the right imaging. Let's push the limits of what we can extract, because we're taking the pictures anyway. Right. It's an incremental cost to do a better job of analyzing them, and use that to guide the biopsy and the subsequent therapy, because these images can be obtained sequentially over time. So Dr. Gatenby was earlier talking about our efforts in multiple myeloma, which is a liquid cancer. There we've got the benefit of a liquid biopsy on a routine basis. The only alternative in a solid tumor is good high resolution multimodal imaging. Right. So we're taking multiple images using different weightings, different acquisition conditions, and then combining them to pull out these different microhabitats that exist in tumors.
With your research right now in terms of developing your algorithmic approach, are you looking for patients to become part of the study? Are you looking to be able to get a broader base of tissue samples? What do you need to really be able to move this along further?
So we're doing two approaches. One, retrospective. What we're trying to do is take a cohort of patients who have had abiraterone therapy and project backwards. Can we take the data that we had prior to that, basically the serum PSA levels prior to abiraterone, based on the response to chemical castration, and can we fit that to a population model which can then be projected forward to predict the outcome of abiraterone where we know it? So we're trying to get retrospective data. That's surprisingly hard to do. And it's an interesting, comment on the state of the world, that organizations that conducted studies on abiraterone are unwilling to give up their data to look at retrospectively, because we've been having problems with that. So the goal after that is then to prospectively use the computational models to predict the outcome in where the physician determines the clinical plan, the treatment plan. We simply take that and say, okay, this is what we think will happen. And if we can get to the point where we can reliably predict response, and then we want to predict both the depth of the response in terms of the decline of PSA, and then also the length of time that response remains, then if we can do that, then the computer models can easily be worked sort of backwards to say, well, what would have been the best approach? How could we have done the optimal thing for the patient? And then when push comes to shove, the question is, if we show that prediction, if prospectively we show that prediction to the oncologist, is the oncologist and the patient willing to take this alternative approach instead of the maximum dose therapy, which is typically what they get now? And we'll see if that happens. But right now we're at the development stage. We believe we have a strong theoretical model. I think we understand the evolutionary dynamics that are associated with both response to anti-androgen therapies and the growth of resistant populations. We think that our computer models we can use computer models to give us the subpopulations present at the time abiraterone therapy is commenced, and we think they will be predictive. So, but that is we're sort of testing that at this point.
Okay. Is there any take-home message you want to pass out to patients and physicians?
Well, I'm not very sanguine about the future of targeted therapies, molecularly targeted therapies, as you know. I do think there is a possibility of informed combination therapies, but as we start getting more complex and the increase in the number of combinations and their timing and their dosing, we cannot do this without math models. We cannot do this without first applying what we know in a mathematically rigorous way. Because otherwise it's too complex. You cannot hope. There are not that many patients on Earth to try out every possible combination. The other approach that we've been promoting is not to necessarily target the molecular or genetic changes within the tumor, but to target the microenvironment of the tumor. And we have shown, especially in prostate cancer, that if you treat prostate cancers in mice, both spontaneous models and experimental models, with pH buffering systems,
right,
we can prevent the emergence of cancer, and if we apply it after the cancer's emerged, we can prevent the formation of metastases. So we can slow down the process. This is not a cure. This is not
right.
We're not proposing that this is a cure, but it can slow down the process long enough to allow possibly other therapies to work, allow more time for the emergence of these other populations. And if you can just slow the process down, you've got hope of a patient dying with cancer and not of cancer.
Excellent. Well, we appreciate your insight, and we look for more research and look for more hope that's going to be coming out of the things you're doing. Thanks again.
Thanks for having us.